So I want to thank you all for staying the course and making it to the end, and I want to thank Matthew and Susan, Debbie, Ben, for inviting me here. It's an honor. You know, we're talking a lot about genetics. You've heard about this gene. You know, genes come from families. I'm the single Wake Forest representative from the UNC and Michigan families that are all here and involved. I feel like, you know, an only child. But I have to tell you, the other thing is, you've heard a lot about nephrotic syndrome today, nephrotic syndrome, heavy proteinuria. So, you know, I don't have any hair left. You know, I've been doing this a long time. And we came into the field 30 years ago saying there's way more to nephrotic syndrome, these common kidney diseases that are given the wrong names. Many of them fall into these same disease categories and present differently. And we were laughed at for a long time. But I want to tell you that at the end of the day, APOL1 is one of the biggest stories in genetics, not just kidney disease, but genetics of any human disease. These are my conflicts, and I'll point out that Wake Forest and I have filed for a patent related to APOL1 genetic testing, so you can bear that in mind. Now, to tell you why I got into this because I saw many young African-American patients who would come to me for high blood pressure. And I would check their urinalysis, and I would check their kidney function and say, you've got high blood pressure, you know, just you're 140/90, take this pill, you know, you'll be fine. And the first question they would ask me is, well, Dr. Freedman, when am I going to need to start dialysis? Start dialysis? I just told you, your kidney function's fine, there's no protein in your urine. They said, Dr. Freedman, they told that to my grandfather, my uncle, my brother, when do I need to start dialysis? The other thing that was striking to me, and this is, you know, the God's honest truth, I would tell all of my patients with advancing kidney disease, you see them every 3 months and check their kidney function. One day, you might need dialysis. And if you get a funny taste, if you lose your appetite, if you can't sleep in the nighttime, but you give them all the uremic symptoms, and you'd say, if any of this happens, call me up. And I had hundreds of patients. And, you know, every 3 months, I would tell them the same thing for 5-6 years. And then my white patient would finally reach the point of needing dialysis, and I'd say, oh, I've got to start you on dialysis. They go, what? You never told me that. And I'd say, I've told you that every 3 months for 5 years. You know, read this note. And I would say the same thing to my African-American patient. And they would, and by the way, when you told the white patient, you had to break out the Kleenex because, you know, tears were flying. So I had the Kleenex ready for my black patients. And their question was, Dr. Freedman, can you put me on the Monday, Wednesday, Friday shift at 7:30 a.m.? And I was like, how do you even know there's a Monday, Wednesday, Friday shift at 7:30? Well, because everyone in my family's on it. So the family clustering was what struck us very early on. And, you know, we just heard about Michelle Wynn. Michelle and I spoke about this a lot. I think one of the biggest breakthroughs we had was recognizing that many African-American families had people with 4 and 5 different types of kidney failure in one family. We don't see that in any other ethnic group. And we recognized that a long time ago, way before everybody else, which led to a lot of stress for me, but we survived it. And the typical story, and this patient's going to turn out to have the same diseases you've been hearing about all morning. 40-year-old African-American woman presents with high blood pressure, well controlled on 2 drugs. She has a kidney function of only 53% with an elevated serum creatinine concentration, but on the urinalysis, there's no blood, there's no protein. It's a normal urinalysis. She's a teacher, she doesn't drink, she doesn't smoke, you know, but in her family, she has a grandfather and an uncle with end-stage renal disease. What's it from? I don't know. High blood pressure, you know, the usual stuff. Nobody knew. And her exam is fine except for mildly high blood pressure. She's thin, she's not hyperglycemic, all her lupus testing, hepatitis testing, all normal, and her kidney ultrasound shows small kidneys. And, you know, this patient's been given a diagnosis of hypertensive nephrosclerosis. We should never use this diagnosis, but you don't have to believe me now. Give me 5 minutes and I'll show you why you can believe me. But, you know, she was 40 then. This is what you see now. She's 52, she's thin, she's not diabetic. And if you look at the great electronic medical records of the day, you know, everything's an abbreviation, right? It's a 52-year-old with GERD, CAD, ESKD. I mean, no one cares what caused it anymore. It's just get the diagnosis down quick. So most of the time, it's just listed as end-stage kidney disease or as due to hypertension or hypertensive nephrosclerosis, and nobody really looked. And I think this term should be abandoned. All it reflects is chronic kidney disease with high blood pressure, which is often secondary hypertension to kidney disease, no proteinuria or low-level proteinuria, normal urinalysis, and somebody who doesn't have diabetes. That's what it means. And you know, there's 2 diseases that cause this commonly. One of the ones is what Rashid just talked about, gene-based forms of glomerular disease or glomerulosclerosis. We're going to talk about APOL1 today. But the other disease is a vascular disease in the small blood vessels, the arterioles, that bring blood to the glomerulus, and that's really not a genetic disease, I'm here to tell you. And shouldn't be called hypertensive nephrosclerosis either. Now, this is the United States USRDS data for the incidence rates. And, you know, I started working way back here in the late 80s, early 90s, and there used to be a great separation between African Americans, Native Americans, Asian Americans, and the low-risk Caucasian group here. And what's happened over time is when you get to the late, 2008, 2009, these guys have all come together. They're all looking like the low-risk European American group, but African Americans have not. And we now see a threefold excess risk of end-stage renal disease in African American, about half due to diabetes, mostly type 2, half due to what's attributed to high blood pressure. And if you look at all the causes of kidney disease in whites and blacks, about 80% are blamed on diabetes, high blood pressure, and chronic glomerulonephritis. But the doctors in the room know this. It's already been alluded to. I think Debbie said it. Somebody shows up in the emergency room with a creatinine of 10, the potassium 7. They haven't seen a doctor in 8, 9, 10 years. You know what? They need dialysis that night. And nobody knows why they had kidney failure. So if they're diabetic, they check the diabetic disease box. If they're not, they check the hypertension box because they just need to get that 2728 form in so everybody gets paid. I mean, that's frankly the problem. Our epidemiology is ruined. And the genetics is saving the day, thankfully. So basically, many of these diagnoses are incorrect. I don't have to tell you there's 8,000 kidney doctors in the United States giving the diagnoses with no standardized guidelines. Very rare to have a kidney biopsy. And the most shocking thing is I've seen office staff, secretaries filling out those forms, not even the doctor. So that's the accuracy of our data. Now, I'm excited to be here at a NephCure meeting. It's great because everyone's talking about glomerular diseases, me too. Here's a urinalysis. So for the patients, for the students, we do a urinalysis, and if there's a lot of protein in the urine, we know it's a glomerular disease. That's minimal change, FSGS, membranous glomerular, the stuff we're talking about. But if there's very little or no proteinuria, well, then it's not in the glomerulus. It's an interstitial kidney disease affecting other cells or the blood vessels. Well, the problem is that when you're talking about APOL1-Associated global glomerulosclerosis, it presents just like these diseases with a normal urinalysis and no protein way more often than it presents with proteinuria, which is a blasphemous thing to say at a NephCure meeting, I'm sorry. But the fact is that what you've heard about today is nephrotic syndrome, bam, 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 over the head. More people with APOL1 present with no protein or minimal protein than nephrotic syndrome by far. So the doctors have to be on the lookout for this so we get the diagnosis right. And I just want to pummel hypertensive nephrosclerosis a little bit more. Bear with me. I've had 20 years of grants being rejected about this, so I'm getting back at it now. But, the bottom line is that if you look at high blood pressure treatment trials, like the Mr. Fit trial, the Australian therapeutic trial, these are trials of thousands of people with high blood pressure. By the way, they had to have normal kidney function. In those days, normal kidney function was a creatinine less than 1.5. That's not normal kidney function. Every doctor will tell you. The patient I presented to you with 50% kidney function had a creatinine less than 1.5. So that's a group who was thought to have essential hypertension, but many of them had a little kidney disease here and there and got in the study. The fact of the matter is, if you followed them for years and years, these guys got treated. These people weren't even treated. They were observed in Australia. 1 in 1,000 patients had a doubling of creatinine to 2. Some of them already had kidney disease, as I told you. They got in with a little kidney disease. 1 out of 1,000 got a creatinine of 2. That's not dialysis. That's a creatinine of 2. It's not that common. Late referral to nephrologists, we already talked about. At UAB, Schlesinger reported that the average referral of their patients at UAB who were given the diagnosis of hypertensive end-stage renal disease was less than a year before starting dialysis, many of them just a few days. My favorite story is the physician bias story. This is a study from Johns Hopkins, Tom Perniger, and what he did was he basically mailed a one-page summary, just like the first slide I had of that woman, right, with her urinalysis and her creatinine. So he mailed it to 200 kidney doctors in the Baltimore area. So they were probably trained at Hopkins in Maryland. That's where they were from, I guess. And he told 100 of them that it was a white patient. Told 100 of them it was a black patient. Other than that, there wasn't a word different on the page. It was the same exact case. If you told them it was a black patient, they were twice as likely to call it hypertensive kidney failure. If it was a white patient, oh, it was chronic glomerulonephritis, different disease. So we have a little bias built in from medical school. I'm going to show you the kidney biopsy data. But finally, the big studies from the NIH, the African American Study of Kidney Disease and Hypertension, the SPRINT trial, which just came out in the New England Journal, the systolic blood pressure intervention trial, show that lowering the blood pressure to very low levels with ACE inhibitors and all the drugs nephrologists like really didn't make a big impact on slowing progression of kidney disease that was thought to be due to high blood pressure. So the answer is it's probably not due to high blood pressure if lowering the blood pressure doesn't get rid of it. And a lot of these were mild cases. It still didn't stop. So remember I told you the disease that presents with no protein in the urine could be a vascular disease or a glomerular disease. Well, this is the vascular disease right here. This is a patient who died in a motor vehicle accident with chronic kidney disease, attributed with high blood pressure. And you see the blood vessel is just blocked. The intima, the small inner layer, the media of the vessel has excess collagen, excess cells. So basically, no blood can get through that blood vessel to the all-important glomerulus, which is the filtering unit of the kidney, the glomerular capillary, which contains the podocyte, the cell we've all been talking about. So if nothing can get through there, the blood can't get cleaned. But the point I want to make is this is a 20-year-old, a 40-year-old, and a 60-year-old patient who did not have high blood pressure, who died suddenly in a motor vehicle accident. And they looked at the same arteriole that's affected with high blood pressure. And you know what? As we age, those same kind of changes are occurring. Now, hypertension makes it much worse, no argument. But you see, this vessel in the 60-year-old looks more like that than in the 20-year-old. This guy does not have high blood pressure. Smoking, high cholesterol, a whole host of factors. This traffic driving to Charlotte last night gives you that. It's incredible. And then what happens is no blood gets into this all-important glomerulus. So what you see is this is a stain of the glomerular basement membrane, the capillary membrane. It's all wrinkled because it's not getting perfused. It's collapsing. We call it corrugation, like a cardboard box. And there's nothing wrong with the glomerulus except no blood's getting to it because the blood vessel's blocked before it. And what that finally leads to is glomerulosclerosis. And I want you to see this picture because I'm going to show you the APOL1 picture in a minute. It doesn't look anything like this. This is what happens when you have an ischemic low blood flow to the glomerulus. The capsule, Bowman's capsule, is thickened and frayed. You see this pink stuff? This is the urinary space. The pink stuff has collagen in it. And you see how kind of the capillaries have all just shrunk down. And basically, they die off and you lose that glomerulus. This is a vascular disease. This is not genetic. Unfortunately, high blood pressure treatment alone does not seem to stop this kidney disease. I treat blood pressure. I'm not telling you not to treat blood pressure. You don't want to have a heart attack or a stroke. Those are bad things. But I'm just trying to tell you, I would imagine if high blood pressure caused this and I caught it early enough, treating the high blood pressure would stop it. And as I'll show you, it doesn't. And by the way, this is the data. So this is a SPRINT trial, which Wake Forest was the coordinating center for SPRINT, actually. And this is a New England Journal paper from 2015. You can't see this, but the primary outcome of, basically MI, acute coronary syndrome, stroke, heart failure, or cardiovascular death was significantly better in the group who was brought to a systolic blood pressure close to 120 versus leaving them at 140. That's the main outcome of the study. But you got to look down on this because they actually looked at the people who had chronic kidney disease at baseline. And to get into SPRINT, you couldn't have diabetes, you had to have high blood pressure, and you had to have less than 1 gram of protein in the urine per day. So really, that you tend not to think of a glomerular disease, but it is often a glomerular disease. And if you look at all the effects of the final renal outcome, doubling of creatinine, needing dialysis or a transplant, none of them were changed by blood pressure treatment in this group with pretty mild kidney disease at the start. Matter of fact, if you looked at people who didn't have kidney disease at baseline for a reduction in kidney function, it was actually statistically significantly higher risk in the group with a low blood pressure. So if you brought the blood pressure way down low and you dropped off blood flow, by the way, this is 3.5-year follow-up, so it's not an acute hemodynamic effect. But the bottom line is treating high blood pressure in this big study, nearly 10,000 people, blacks, whites, Hispanics, Asians, didn't slow the progression of this type of kidney disease. Okay, so I told you I got into this because of family clustering of kidney disease. This is an ad in Brussels to take the train, because on the train in Brussels is a bathroom, and they wanted you to know. Now, when a geneticist looks at this, you think this is an X-linked disorder, because only the men are affected. She's fine. But anyway, this is what got me interested in this. And these are our African-American families. And by the way, these are pedigrees, people in solid bars or on dialysis. Now, I treated all these family members. I know these people. And we have 30,000 DNA samples at Wake Forest. Our patients, back to the early 90s, have stepped up and participated in studies. The doctors in Charlotte, the doctors all across North Carolina, South Carolina, Georgia. We have doctors from Columbia here. Every one of these groups, it was the most amazing thing. You know, I got phone calls from nephrologists saying, your study coordinators at the unit across the street, the other group, our competitors, how come you're not coming to our group? And they were stepping up asking to get their people tested. And that's what led to the APOL1 discovery, that participation. And these are black families with multiple people on dialysis in one family, 3 brothers, one of their children. This person was thought to have hypertensive kidney disease, type 2 diabetes, chronic glomerulonephritis, and type 1 diabetes. But my point is, almost every family has somebody who was thought to have hypertensive kidney failure because they had low levels of proteinuria. Had they had high levels of proteinuria, they'd have gotten a biopsy and had FSGS. But the low-level proteinuria ones are blamed on high blood pressure and not biopsied, and that's where everybody went wrong. So we started collecting DNA. And by the way, this is the other big hypertension trial, the African American Study of Kidney Disease and Hypertension Study, a landmark trial. And I want you to see that if you put people on high-dose ACE inhibition with a low blood pressure target and you follow them over 10 years, 60% of these African Americans who were thought to have hypertensive kidney failure had a doubling of creatinine, ended up on dialysis, or died. And the fact is, very few died. The outcome was really renal. It was a doubling of creatinine or dialysis. So the standard therapies that we thought would work in African Americans with presumed hypertensive kidney failure really failed dismally. And we went and got DNA samples from all these people. And they, in fact, a lot of them had APOL1-Associated Nephropathy. So this is a biopsy study from ASK. And this study, the African American study of kidney disease and hypertension, had GFRs, kidney function, 20 to 65% of normal. And this lesion popped up, which was looked at as focal global glomerulosclerosis, but nobody quite recognized that as a primary kidney disease. They actually blamed it on high blood pressure. This is what it looks like in a much better picture. And what we call this is solidified glomerulosclerosis. And these people don't present with proteinuria. You know why? Because there's no capillary there for protein to leak. It's plugged up. And for the doctors and the medical residents and the house staff and maybe a lot of the patients and their families, you know that we characterize FSGS by one of 5 lesions, right? We call it tip lesion, a perihilar lesion, collapsing glomerulopathy, or not otherwise specified. Well, we kind of missed a lesion, because this is the 6th lesion of FSGS, solidified glomerulosclerosis, and it presents with no proteinuria or very little proteinuria. It's often blamed on hypertension. So that led us into looking for genes. And I want you to see this paper. My favorite story is in 2012, a very good friend and colleague, Carl Skorecki in Israel, published a paper, Hypertension Misattributed Kidney Disease in African Americans. This accompanied our paper on the ASK study, where we got DNA from the people in that study who lost kidney function in spite of treatment, and we showed APOL1 was significantly associated with kidney disease. I'd just like to remind him, in 2012 he published this, that we had this paper in 1995. We actually submitted it in 1993. It took me 2 years to get it accepted because it was a tough time, where we said the same thing, that there was hypertensive nephrosclerosis was not the disease. It was a primary kidney disease, secondary hypertension. Genes were involved, and there might be one kidney failure gene that could cause 7 different types of kidney disease in a single family. And the great thing was that while everybody was laughing, thinking we were nuts, 2 years to get a paper accepted, we were collecting DNA from all the practices in the area that believed in us. And now the most amazing story in selection and Darwin's survival of the fittest comes true. So this is trypanosome, a parasite which causes African sleeping sickness, an infectious disease. This is a tsetse fly with a little stinger, and it transmits this parasite, and it stings somebody. This is a young African girl with a canker sore on her leg from a sting that transmitted the parasite into her, and she's at risk for African sleeping sickness. Well, the biggest breakthrough came working with Martin Pollack and his group at Beth Israel Deaconess, Jeffrey Kopp at NIDDK, and our group at Wake Forest, showing that APOL1, which was a gene known to protect from trypanosomes, known to kill this parasite, there was a variant that was associated with severe kidney disease in African Americans. There's the trypanosome in the bloodstream with red cells, and if you took plasma from people who had one copy of the APOL1 risk variant, and this is really a great story, because what I'm here to tell you is in the next 5 years there will be a treatment for this. This disease will be eradicated, and it causes 30 to 40% of all end-stage renal disease in the African American population. And then when we have a treatment, people will be genetically tested, and they will get biopsied because we'll have something to offer, and they may not have proteinuria. So I see a cure for this in the very near future. But the interesting thing is you need 2 copies of these kidney failure variants, the G1 and G2 that Dr. Hippen presented earlier today. If you have one, you're protected from African sleeping sickness. But if you have 2, you're at risk for kidney disease. It's the same story for malaria and sickle cell disease, right? If you have one hemoglobin S variant, you're a carrier, sickle cell trait. You don't really get very sick. But you're protected from malaria, which is why it got transmitted and carried on. But if you're unlucky and you get a variant from your mom and your dad, you have 2 sickle cell variants, then you got sickle cell disease. For APOL1, it's the same story. One variant doesn't increase risk of kidney disease, protects from infection. And I want you to see, this is plasma from people with one G1 variant or one G2 variant. And for those of you who are curious, why did we name them G1 and G2? First author of the paper, Giulio Genovese. That's the truth. That's the G1, and that's not a joke. That's the truth. So look at the lysosome in that parasite. It's swelling, and that lysosome is going to rupture and kill the trypanosome. This is the wild type, which we now call G0. That's a perfectly happy, healthy trypanosome swimming around in a jar. So the G1 and G2, even in one variant, kill the trypanosome, which is why it was selected for. What's most amazing, as Dr. Hippen told you, 13% of all African Americans have 2 copies. There's 45 million African Americans in the United States, and there's more people with risk variants in, Caribbean, South America, Africa, for sure, Africa. So 13% have 2 risk variants. Another 38% have 1. So 51% of all African Americans have a risk variant, and 49% don't. So it really was so protective during these sweeps of African sleeping sickness, it got to high frequency. This mutation came about very recently, less than 10,000 years ago. And you know why we know that? It's because it's not present anywhere else on Earth. It's not in Europeans, Asians, Hispanics. And if you read papers about Hispanics in New York, where I'm from, it's the Puerto Rican population, some other populations that are admixed with African populations. So it's not the Hispanic population, it's the admixture in the New York area with African populations that carries the risk. So now we know there's a spectrum of APOL1-associated disease. The disease everybody got wrong and caused hypertensive nephrosclerosis, it's the solidified glomerulosclerosis, which has very little proteinuria. But as your proteinuria goes up, you get to the typical FSGS that everyone's been talking about, where a segment of the glomerulus is involved. The rest of it's normal, and it's focal. Many glomeruli are not involved at all. And then you get a collapsing glomerulopathy, which is the most severe form of FSGS. And the association for these are just off the map. I mean, these are almost Mendelian diseases. You don't see this in common complex disease. Sickle cell nephropathy, severe lupus nephritis, and kidney transplant failure from the donor kidney are all associated with this spectrum of APOL1-associated nephropathy, which is a podocyte disease. So even if there's no proteinuria, it's a podocyte disease. And just to sum up the story as I get into some of the newer data, I told you 13% of African Americans have 2 risk variants. As Dr. Hippen told you, about 20% of them are at risk for kidney disease. 80% will not get kidney disease, so we're actively searching for the second hit. HIV infection is a definite second hit. Interferon, the medication we give, is a second hit. And by the way, there's a lesson in there, I'll tell you. But we're looking for other second hits. The population attributable risk, you just heard many speakers talk about FSGS as dozens of diseases. I was taught hundreds of diseases. And that's true, except if you're African American. Where in the African American population, 70% of all cases of nephrotic FSGS are due to this single gene. So it's not dozens of diseases. 70% of it's one disease in African ancestry populations. But it's not true in whites and Asians and Hispanics, where it's many different diseases. HIV-associated nephropathy, 70%. So the point is, if this mutation didn't happen in sub-Saharan Africa less than 10,000 years ago, 70% of all cases of FSGS and HIV nephropathy would go away. And you know what that would mean? The risk for non-diabetic kidney disease in African Americans and Caucasians would be the same. This explains the excess risk for non-diabetic nephropathy in African Americans, this single gene. 2 changes in the gene. And the thing is, because it's only 2 changes, it's going to be treatable. If it was hundreds and thousands of changes, like the polycystic kidney disease gene variants and Alport's syndrome, which is problematic. When you have 2 coding variants, you can treat that. The odds ratios, the risk of disease, are sky high. 30 to 40% of all end-stage renal disease in African Americans relates to the one gene. And the poorer graft survival in kidneys transplanted from African American donors, and the poorer outcomes in lupus nephritis in African Americans are likely related in part to APOL1. So when we think about this in the future, when there's a treatment available, who might want to get screened? Well, patients who have chronic kidney disease, definitely those without diabetes and low-level proteinuria or nephrotic syndrome. Rashid just showed you the data in steroid-resistant nephrotic syndrome in children. APOL1 strongly associated there. But you don't even have to have nephrotic syndrome. But the key is many people with type 2 diabetes, what does type 2 diabetes present with? Nephrotic syndrome, proteinuria. So how do you know? Hypertension. So how do you know if they have diabetic nephropathy or FSGS and they just happen to be diabetic? Diabetes is common in African Americans. FSGS is common in African Americans. Well, you could do a kidney biopsy, which is not often done. You could, if it's an atypical history, you might think of it. But if somebody's been diabetic 10 years or so, most doctors would just check the diabetes box. APOL1 can actually tease those out and pull out the ones that are probably not diabetic nephropathy. Living kidney donors, a lot of places are testing them already, especially from families that have FSGS members. Deceased kidney donors, I'm going to show you the data and a new study that's starting up. Patients with HIV, lupus, and sickle cell, and for family planning purposes. When a treatment comes out, this is going to be important. Now, we already think APOL1 genotyping is going to revolutionize kidney transplantation. Dr. Hippen talked a lot about this. Many transplant centers are already screening African-American living donors. The comment was made this morning, we don't have rapid turnaround testing for deceased donors. Well, actually, Wake Forest does offer 3-hour turnaround time APOL1 genotyping with an intent for if it was ever useful in deceased donor transplantation. Just as long as it takes to tell if that donor is HIV positive or Hep B or Hep C, we can genotype APOL1. The limiting factor is getting it to the center. So if a kidney comes in Alaska, getting it to Winston-Salem is a little problematic. But it can be done quickly by the PCR-based methods, and I think this is coming. I think it's going to be standard one day. So the NIDDK just started a consortium. Rashid left the room, but actually Duke, Chapel Hill, Carolinas Medical Center are all working with Wake Forest, ECU, Dr. Barchman this morning. We've all banded together down Tobacco Road, and we're going to be working on the APOL1 long-term transplantation network consortium to see the effects of APOL1 on deceased and living donor transplantation. And as Dr. Hippen said, it's just not ethical to use self-reported race to say this kidney is at higher risk for failure when you know the gene that underlies most of that risk. Replace the social context phenomenon with real data genotype. And that's what APOLO is going to do. And we're going to show you how it more precisely defines donor quality. We think it will lead to fewer discarded kidneys and more transplantations. So the first data that came out about transplantation was by Kevin Abbott and his group. Actually, this is not the first, but one of the earlier studies. And these are just cadaveric kidneys in the old days, we called it. The outcomes of those transplants based on the race of the deceased donor. And you can see donors of other races, this is the graft survival at 3 years, like 90%. But if you got a kidney from a donor of African ancestry at 3 years, the survival was like 75%. And it was very early on that the separation starts, that these kidneys start to fail. So that was a striking finding nobody could explain. Well, our group, this is a paper Ben talked about this morning, Amber Reeves-Daniel, looked at all the African-American deceased donor transplants at Wake Forest over many years. We got the DNA from the donors, and we genotyped it. And 136 transplants from 106 donors. 2 of the kidneys had 2 risk variants, 114 had 1 or 0. And the findings were shocking. This is the outcomes. These are all African-American donor kidney transplants. Now, the recipients could have been white, they could have been black, could have been Hispanic, didn't matter. It's the donor that we were tracking. And if your kidney came from a donor with 2 risk variants, they did much worse than if the kidney came from an African-American with 0 or 1 risk variant. By the way, the African-Americans with 0 or 1 risk variant look just like European donors. So that suggested to us the poorer survival of donor kidneys in African-Americans could relate to APOL1, and it also showed that it was not the recipient genotype that mattered. And by the way, this is the only study that has histology or biopsy in every failed transplant. And most of the transplants from the APOL1 failure group failed from FSGS, solidified glomerulosclerosis, or scarring of the kidney, not rejection. They had an intrinsic kidney disease from the donor. So this was striking. But nobody believes one study. Dr. Gibson says you got to replicate, and we did. We brought in UAB, Emory, Minnesota. We got it up to 1,153 deceased donor kidney transplants at 113 centers. This is the 2 risk variant group. This is the low risk variant group. At 5-6 years, there's twice the risk of graft failure if your kidney came from an African-American with 2 risk variants. It's not that African-American kidneys fail. It's this gene causes kidney disease. You have to get past the social context into the biology. What was also striking is we looked at APOL1 compared to all the things transplant doctors love to look at. You know, they like to look at donor age, sensitization by panel reactive antibodies, recipient age, HLA matching, cold ischemia time, standard versus expanded criteria donation, yada, yada, yada. All the stuff that for 20 years everybody cared about. Nobody cared about APOL1. In a multivariate model with everything mixed in together, equal effect, you want to know which predicted outcomes. APOL1 had the highest hazard ratio, higher than anything else that we standardly use. The lowest p-value, now I'm not telling you it's more important, but it's as important as all those other risk factors in a multivariate model. So this was striking data that led to the APOLO study in deceased kidney donation. And you know, one of the people I think that Ben mentioned as his mentor from UAB is a good colleague of ours at Wake Forest, Bruce Julian and Bob Gaston. These guys are legends in transplantation from UAB. And Bruce just brought up the simple question. You know, we went back to this study where we had 1,153 transplants, and we said, you know, we're using this thing called the Kidney Donor Risk Index because now we want to match the best quality kidney with the best quality recipient. We don't want to give a great kidney from a unfortunate 20-year-old who fell off a motorcycle and give it to a 75-year-old with a stroke who might only live 2, 3, 4 more years. We want to save that kidney for a young recipient who's going to have the longest life and needs a good kidney. Many patients were dying with functioning allografts. The kidneys were working and they died of a heart attack or a stroke. That's not good. You lose that kidney from the pool. So the KDRI was intended to optimize the matching of donors and recipients. And that would lead to longer graft survival and keep people off dialysis more. So a very good reason to do it. The problem is, this is for deceased donors to tell their quality. Of the 10 factors, one of the factors is, are you black or not? Are you African American or not? And if you're African American, that kidney's downgraded. Because of the first data I showed you, kidneys from African American donors do worse. Now, to be fair, this was developed really before APOL1 hit the mainstream, to be fair. It was starting to gain traction, but it wasn't commonly accepted. So what Dr. Julian at UAB said was, why don't we just stick the genotype in instead of the race and see what it would do? And it's a great story. These are the same transplants from that paper I just showed you that we published. This is the Kidney Donor Profile Index, which basically says that kidney, how does it do compared to all kidneys transplanted in the prior year that look the same, from the same kind of donor. And I want to show you the current guidelines don't matter if you have 0 or 1 APOL1 variant. This is the non-risk group. This is the risk group, because APOL1 is not considered. So the current number is about 70%, 69% and 71%. But when we substituted the genotype, I want you to see that the current group who has a low-risk kidney improves down to 53%. So now that kidney that was looking is looking okay. It's looking just like the average kidney from transplanted the year before. But what if the donor had 2 risk variants? It really wasn't 70. It's 88%. It does worse than almost 90% of transplants. That's a huge difference, 53% to 88%. What does this mean? Well, you know, lots of 70%, 80%, and 85% kidneys are discarded. Nobody wants them because they're high risk. The fact is, let me just put this to you this way. 13% of African Americans have 2 risk variants. So 87% of the time, we're downgrading that kidney for no reason. 87% of the time, it's going to look like this. Only 13% is going to look like that. What's going to happen? Number one is you're going to discard less kidneys, more transplants. And these are good quality kidneys that are going to function fine. They're not high-risk APOL1 kidneys. So I'm trying to show you all this hocus pocus, gene expression, genetics is now coming into the clinic. These data will be used. The NIH is studying this prospectively, and we're going to look at every African-American donor kidney, living and deceased, for more than a year. Probably 1 to 2 years are going to be collected across the United States. And Wake Forest is leading the study and is a participating center with all the North Carolina sites and CMC. So this is very exciting. The other thing this data taught us is the recipient genotype, the person getting the kidney transplant, didn't matter. It's the kidney itself. So circulating proteins are not playing a role in this disease. Dr. Barchman talked about plasmapheresis and getting that factor that causes FSGS out of the circulation. That's not APOL1-associated disease. And as Dr. Gabadishan just said, genetic kidney diseases don't recur. Well, genetic FSGS, I should say, does not recur typically after transplant because you've got a gene defect that caused your kidneys to fail, but you're getting a perfectly good kidney from somebody else that doesn't have that defect. That's not the recurrent disease. That's not the immune type of FSGS that many people have talked about today. So we know it's not the circulating protein. It's actually the gene expression in the kidney itself. The other thing, a new study has just come out where we gave the APOL1 gene variants to the kidney cell, the podocyte of mice, and it showed that it causes disease. It's not just associated. Now, my other story, I got to tell you all these stories. You know, I told you my grants were ripped up for 20 years. The first 10 years, they were ripped up because everybody said, we don't need to do this in people. It's impossible. I have the perfect rodent model of hypertensive kidney disease. The spontaneously hypertensive, stroke-prone, doll-sensitive, yada, yada, yada. That's fantastic. Except mice, you know, rats, sheep, pigs, dogs, cats don't have an APOL1 gene. It's kind of hard to find the gene that causes a human disease if your model doesn't have the gene. So what we did, what's been done by groups is the gene's been put into the animal. It didn't have it. And I'm not going to, oh, well, that's an important slide. So the bottom line is it's causative. It's not just an association. It's true. The interesting thing in my mind is that 4% of patients with these 2 risk variants get the nephrotic syndrome with focal segmental glomerulosclerosis, FSGS. Half of people who have HIV infection and have the 2 risk variants went on to get HIV-associated collapsing glomerulopathy before we had medications, before the antiretroviral therapies were available. 50% of people with HIV who had the risk genotype got this FSGS collapsing lesion. About 20% of all people get low-level proteinuria. And it's very interesting that you get these different frequencies. Why does the glomerulus, why does the capillary look different in everyone? Why was HIV-associated nephropathy at one point every grant the NIH was getting? We got to know why HIV is causing nephropathy. It's the most rapidly growing cause of end-stage renal disease in young African Americans. It's an epidemic. The epidemic's over. We got antiretroviral therapies which treated HIV. Kidney disease went away. So the lesson is you can be genetically susceptible to a disease, but if the environment pulls the trigger on that disease and you can block the environment, you can cure a genetic disease by blocking the trigger. And HIV-associated nephropathy in somebody who takes their medicines is just a disease of the past, even if you have the genetic risk. Okay. So we've always said that 13% of African Americans are genetically at risk, but they're second hits. Gene-gene or gene-environment interactions. I told Ben this morning we haven't found any other gene-gene interactions in thousands and thousands of people, which is good because it suggests it's environmental interactions which we can treat. And depending on which environment interaction, you get a different picture. You get a different type of kidney disease. I'm just going to tell you, there's kidneys made up of many different cells. The podocyte is one of them. But the fact of the matter is that the APOL1 protein and the mRNA, the building block of the protein, the template for that protein, are found in the podocyte. They're found in the tubule cells, which is kind of the interstitium of the kidney, not the glomerulus. And it's found in the vascular cells of the glomerulus, the capillary cells, endothelial cells. They're not found in a cell called mesangial cells, which we think are important in diabetic kidney disease. Not there at all. You don't see the mRNA or the protein. This is the study in the transgenic mice done by Kettle and Sustak's group, where basically they took mice that don't have this gene, they gave them the wild type non-risk variant or the G1 or G2 risk variants. Look what they get. Solidified glomerulosclerosis, just like in people, right? And a lot of them got just a little proteinuria, not heavy proteinuria, just like in people, with solidified glomerulosclerosis. So now it's not gene association, it's causation. Very important point. And finally, I want to wrap up. I know that there are families here and all. I want to give you kind of the simplistic guy's view of how this is causing kidney disease. I'm a kid who grew up in Brooklyn, New York, and I don't have fancy genetics training. I just did clinical nephrology, but the story is very exciting. And this is a paper by Martin Pollack's group, the group that really discovered this gene, where they proposed that the APOL1 protein, remember, it punches a hole in the lysosomes of that trypanosome, the parasite. And remember the lysosome swelling and enlarging until it ruptured and killed the trypanosome? Well, they said, it looks like it's punching holes in the membrane of human embryonic kidney cells. Then potassium's leaking out. And when you get a low potassium in the cell, all these stress kinases get activated, and we think that's what's doing it. So that was the initial model. But work from our group, Li Jun Ma in our group, who's absolutely fantastic, through a whole bunch of fancy gene expression studies in transfected kidney HEK cells, showed actually mitochondrial pathways. The mitochondria is the powerhouse of the cell. It generates all this energy that really drives cell function in every cell of the body. And what he showed was that in people with the G1 and G2 risk variants, they had reduced mitochondrial function and reduced spare capacity in their mitochondria. So it looked like the G1 and G2 variants that cause kidney disease were damaging the mitochondria. By the way, he measured the potassium in the cells, and that was before the potassium went down. So the earlier study, which suggested it was the potassium leak comes because the energy function of the cell, the mitochondria, are damaged first. And then he went on to show that the APOL1 protein co-localized with mitochondria and was found there. I will then tell you that our good friend Carl Skorecki's group, right after our paper came out, showed the same thing. Intracellular APOL1 risk variants cause energy depletion, co-localized with mitochondria, cause mitochondrial dysfunction. This is a kind of a cartoon from a good friend of ours, John Cedar, Case Western in Cleveland, where he looks at the trypanosome, that parasite, and a human kidney cell. And in the trypanosome, the APOL1 protein is punching a hole in the lysosome, and what it does is it becomes a chloride channel. It allows chloride to enter the lysosome till it swells, ruptures. And what we think happens in the kidney cell is it's punching holes in intracellular compartments, mitochondria, and the cell membrane. So we basically think that this APOL1 protein, when the pH changes, becomes a chloride channel, punches holes in membranes all over the cell, leading to cell death. And this paper, just to show you how up-to-date NephCure is, this paper came online like 48 hours ago. And it's by the group in St. Louis University, where they showed that APOL1 protein has a pH-switchable permeability to these phospholipid vesicles, the membranes. So at a low pH, the APOL1 protein's hanging out in the cell. At a neutral pH, at a neutral pH, it's hanging out in the cell. When the pH drops, the APOL1 risk variants insert in a cell membrane, the mitochondrial membrane, lysosomal membrane, plasma membrane, and then at a neutral pH, it becomes a chloride channel, allowing chloride to exit. So very elegant. I'm just here to tell you, you don't even need to know all these pathways. When you have two coding variants in a gene, there are ways to turn that gene off. And I think that's where the field is going, where it comes to treatment. And just to finish this up, I want to talk very briefly about the second hits, and I'll stop. This is David Freedman, who works in Martin Pollack's group at Beth Israel Deaconess. We know that these APOL1 risk alleles are toxic gain-of-function mutations, which nobody thought they'd be. When you have an autosomal recessive mutation, you don't expect a gain of function in the gene. So this gene disobeys every basic rule of science. But what's very exciting is that when the immune system is upregulated, you make more of the APOL1 gene. So remember I told you there's a second hit, why only 1 out of 5 people gets kidney disease and 4 out of 5 don't? We think the second hit is anything that upregulates APOL1 gene expression, so certain types of inflammation. And a big breakthrough to this story came from the Columbia group in New York, Vivek Dagadi, Glenn Markowitz, pathologists, where they noticed that people who were getting interferon therapy, we used to use interferon for hepatitis. Now we have all these new, drugs that are really, really fantastic. But in the old days, we gave interferon. And they noticed that some people got this collapsing glomerulopathy. And the group in Beth Israel said, I'd like to get a DNA sample from those people that developed this. And this very exciting story, David Freedman and Martin Pollack in Boston, showed that every single patient that had this lesion from interferon had 2 risk variants in APOL1. It was 100%. So what it shows is that interferon was a second hit. HIV infection, which is a viral infection. What do viruses do? When your body wants to fight off a common cold, you make interferon, right? What about patients with lupus? I told you lupus nephritis is in this APOL1 spectrum. Lupus patients are inflamed. They have very high interferon levels. We can see signatures of it in the kidney biopsy. So actually, we think that the upregulation of the immune system ends up producing more of the APOL1 mRNA and protein. That's the second hit, whatever turns that switch. So, we've looked at other viruses to see if they could play a role, like HIV. We looked at viruses that live in the kidney, like HIV does, BK and JC polyoma virus. We looked at viruses that live in lymphatic cells, CMV and human herpes virus 6. And I'm going to end, this is my last slide. This was a shocking finding for us. We actually found that JC polyoma virus, which is a virus that lives in the kidney, was protective from APOL1. And at first, this made no sense, because we thought any virus we'd find like HIV would be bad. But the fact of the matter is, JC polyoma virus is an interesting virus. It doesn't really cause kidney disease in transplant patients, Ben. It's BK, right? JC is not pathologic very often for the kidney. It causes problems in the brain, unfortunately, because I was thinking a treatment for APOL1 could be to give everybody JC polyoma virus, but then it affects the brain. But you want to get a little shocking data? 30% of us sitting in this room right now have JC polyoma virus in our urine, right now. We're not immunosuppressed. We're not on medication. 3 out of 10 of us have JC polyoma virus. So what we think is that JC polyoma virus really doesn't hurt you. And the fact is, people with APOL1 that did high-risk genotypes that didn't get kidney disease, they have a low immune system. They have a cooled-off immune system, and they're like, hey, this JC virus isn't bothering me. Hang out. Come along for the ride. But if you're a hyper high immune system guy, type A guy like me, you say, I don't want any viruses in my body. You got to go. Well, when you're eradicating that virus, you're more likely to scar your kidney too, because your immune system's upregulated. So interferon triggers it, HIV, lupus, high interferon levels. People who just are happy to be colonized by a virus may have a lower innate immune system. You've heard a lot about innate immune systems today, and I think it plays a big role in APOL1-associated nephropathy too. So my conclusion is nephrologists have to think outside the box. Mild to moderate high blood pressure just doesn't cause chronic kidney disease very often. We need to think about diseases like glomerulosclerosis. APOL1 is very common in African ancestry populations. All the other ones Rashid talked about earlier today, the 50 genes that cause steroid-resistant nephrotic syndrome, they all cause glomerulosclerosis. There's no good animal model. You got to do the studies in people. We're all genetically different. You've heard many times the Asian population is important to know. They may be different than the African American or European American. The gene frequencies are different across populations, which is why APOL1 is so common in African populations. It's absent in everybody else. It's not even rare. It's almost not there. And emerging evidence supports mitochondrial dysfunction or the energy apparatus being disrupted in APOL1 nephropathy and roles for the innate immune system. So I'm going to stop there, and I really, really appreciate the opportunity to speak here. Thank you so much for inviting me, and I'm happy to take any questions.